Hello, everyone. My name is Shannon Tewari, and I am a second-year medical student at OSU Com at the Cherokee Nation. Today, I am excited to share with you the findings of our research project titled Hidden Statistics: Examining the Obesity Epidemic Across American Indians and Alaska Natives Using Self-Reported Identity Compared to Imputed Racial Categories. Obesity is a major public health issue in the United States and is associated with various metabolic diseases, including cardiovascular disease, type 2 diabetes mellitus, and cancer. A recent systematic review showed that approximately 41% of American Indian and Alaska Native populations are obese. These high rates are also seen in AIAN youth. When race is measured, populations within the United States are often separated into five oversimplified categories of ethno-racial groupings, including white/Caucasian, black/African American, Asian American/Native Hawaiian/Pacific Islander, Hispanic or Latino, or American Indian Alaska Native. The disaggregation of these ethnic groups into smaller subgroups has been recognized as a beneficial approach, but there is still little research that examines such data. The lack of representative data for certain populations can be detrimental during public health crises such as obesity. Our objective was to identify obesity rates among high school students who identify solely as non-Hispanic, American Indian, Alaska Native, or AIAN in comparison to a disaggregated approach that includes all youth identifying as AIAN alone or in combination with other ethno-racial groups using the 2021 Youth Risk Behavioral Surveillance System, also known as YRBS. For our methods, we conducted a cross-sectional analysis of the 2021 Youth Risk Behavior Surveillance System, a nationally representative survey that is conducted biennially and funded by the CDC. Respondents were included if they self-selected an ethno-racial category or were categorized into a group within the imputed race-F variable. The obesity rate was measured using the variables age, sex, and BMI, which were acquired and calculated from the questionnaire. Obesity was documented when the students were at or above the 95th BMI percentile. For our results, according to the imputed race-F variable, 119 high school students were classified as AIAN only, with 30 being classified as obese. In contrast, 664 participants self-identified as AIAN alone or in combination, with 149 students being classified as obese. Our self-report data also yielded a total of 128 AIAN only high school students, with 31 students being classified as obese. Additionally, obesity rates varied among the other AIAN subgroups, such as AIAN and white/Caucasian, AIAN and black, AIAN alone with Hispanic or Latino ethnicity, or AIAN in combination with one or more race. So what do these results mean for us? We believe that the disaggregation of ethnic groups into smaller subgroups by allowing individuals to self-report ethno-racial status limits bias and provides a more accurate and representative data set. Accurate data representation on common health issues is crucial for adequately reporting obesity and other metabolic disorders in conjunction with race and ethnicity. Additionally, in terms of health inequity, classifying AIAN populations as non-Hispanic or Latino, single race limits the population size and hinders the amount of public resources that are allocated towards AIAN health and well-being. In conclusion, our results show that the incidence of obesity among Indigenous children in the U.S. is more significant than current CDC data estimates. It is important to know that when inclusivity is exercised and multiculturalism is acknowledged, individuals identifying as AIAN alone or multiracial can be recognized. Addressing these current inequities is an important aspect of governmental resource allocation and public health measures to improve health outcomes for AIAN individuals and families. Finally, it is important to acknowledge that there are also differences in the prevalence rates of childhood obesity among different ethno-racial subgroups of Indigenous peoples in the United States. In medicine, advancing our cultural competence and situational awareness of individuals in pediatric and primary care settings leads to improved interventions and health outcomes that pertain to a broader community of Indigenous individuals. Additionally, this allows us to create a healthcare environment that fosters inclusivity and accessibility while focusing on preventative health. I hope you enjoyed this presentation, and I thank you for your attention.